I'm thinking about a listener out there who is a physical therapist that sees, the gamut of orthopedic conditions, but that most common low-hanging fruit is that back pain that may be radiating down the leg. And historically, perhaps that patient was shuttled through right to the specialist, the surgeon, or the neurologist, to have them assess and to see if they were a candidate for, injection or medication or surgery and the like. And that clinician out there who's listening is in maybe a large hospital system. So
Mhm.
whereas that older model might be to go to that one who delivers the most invasive and highest cost care, yes, the patient might feel that they're being handled in good care and with the most competency or most competent clinician out there. How does that clinician out there listening who provides perhaps a very low tech type of service, but high quality, and the effectiveness has been demonstrated in their care with a patient, like someone with back pain and sciatica?
Yeah, it's a great question, and I think it's a good illustration of how disruptive innovation could impact a particular area of care. And as an illustration, if there's an existing provider that treats these sorts of patients but tends to refer them to more complicated, surgical specialists for further treatment, that's sort of the status quo, and that provider is almost disincented to want to do something that's cheaper and lower cost, right? Giving a patient an app to self-manage and even self-treat a lot of their musculoskeletal pain often means less revenue for the referring provider, and certainly no revenue for the specialist that would otherwise probably have seen that patient, and no facility fees or revenue for the hospital. And so you can see how the entire industry is already set up to reject a technology like that. On the other hand, that's why in the book we tried to outline all of these different chess pieces that would need to come together for an ecosystem to work and to disrupt that status quo. So it's not just the provider that is willing to refer their patient to this newer, simpler, cheaper, and more available treatment. It's, of course, the patient that sees that as high value, right? So that requires a change in the patient perspective, right? Good care is not necessarily seeing the most complex tertiary care center specialist. It can be self-service, much like high quality can be using your banking app instead of having to talk to a teller to get something done. If it's something that allows you to engage with care 24/7 in the comfort of your own home, that can be high quality. And so you have to be able to find those customers that are willing to accept that as high quality. You have to find the providers that are willing to send patients to this novel delivery mechanism. But then there are all these other parts of the system that also need to participate. I think first and foremost is somebody who would prefer to pay that way. You would think that any payer should be willing to pay for something that's cheaper. But again, the system is not necessarily set up that way. And if there's no billing code in place, if there's no reimbursement process already set up, it can be a challenge. And that's why in the book, we alluded to novel payment schemes like health savings accounts or, systems that were integrated like a Kaiser Permanente that were both payer and provider that could really see the value and could, they would see the direct benefit of those savings. Or large and self-insured employers that, again, being the ones that wrote the checks, they would be of direct benefit if they managed to direct care towards these more cost-effective mechanisms. But you can start to see there's all these parts that need to move in unison for this to happen successfully. And that's often why a lot of attempts at disruptive innovation in healthcare get cut short, because you need to find.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.